Thank you. I think my recorded talk is already given. If
Yes,
that is,
yes.
fine.
We'll
Otherwise, I will.
take off the questions at the end. After GV's talk, there'll be a question answer session.
Let me be very frank. This is not a debate. I've been asked.
Yeah, it's not a debate. It's not a debate.
Because I cannot debate with GV. He will kill me.
I told that already. So we'll.
So this is not a debate. I was asked 10 minutes on how to use drugs diligently on steroid dependent. Hi, Dr. Shobha and Sumit. How are you?
You need a mic, I think.
Hi, Mathew.
Wonderful to see you all people. I'm so sorry I want to come over there, but unfortunately, one of my very close colleagues who were interacting with me, he developed COVID-19. So I thought I'll not come because I don't want to infect you people.
Okay, so anyway, all the best. Get well soon.
I don't have COVID. My
You
test is
don't have. Okay. Okay. Chalo, we can start, I think, Mathew. And,
yes, I think the recorded version is given. Otherwise, I can start from here. What do you want?
Yes. So can we have the recorded version? Can you relay from there?
I can start from here also.
I think that might be better. It will give it a personal touch. Can we show Dr. Mathew's slides, please?
I have no option to share the screen. Can you see the slide now?
No, I cannot see the slides, but can we have his slides? Can you make him the host? Otherwise, then we can see his slide. He's already a host. So Mathew, can you try sharing the screen?
No, I have already shared my slides.
No, we can't see his slides.
We cannot see the, now we can see something. Yes. Thank you, Mathew. We are seeing your slides. And
Yes.
I think we're looking forward to seeing this. Since morning, we've been talking about ulcerative colitis and its complications. And this will be the, what do you call it? The nail in the wall. You're hitting it and telling us whether we should continue to use biologicals or lose out to GV Rao. So Mathew, start.
Now, all are important. GV is very important person. So we need surgeons very closely with us. So thank you so much. And first of all, I thank the organizers for giving me this opportunity to be to present this very important topic. And when we look at the goals in therapy of ulcerative colitis, we know that corticosteroid-free remission is a very important aspect. And we need that sustained and a durable remission. And also we need a prevention of morbidity and hospitalization, colectomy, cancer, etc. So most of these ulcerative colitis patients have a mild or moderate course. But nearly 20-25% of patients can have a more aggressive course. And 20% of patients with ulcerative colitis, they develop severe disease and they require hospitalization. If you look at the cumulative colectomy rate, it is around 10 to 15% at 5 and 10 years. And we know that corticosteroids has got, it gives good remission, but long-term use is not possible because of the short-term and long-term side effects of that. So in that aspect, biological therapy step forward as a very important aspect. When you look at the drugs of ulcerative colitis, we know there is an array of drugs, and it keeps on increasing, especially after the introduction of biologics. Unfortunately, what we see that once the biologics started developing, the immunosuppressives used in IBD has come to a little backward. The research on that has come backward. So coming to corticosteroid ulcerative colitis, the mainstay of treatment in moderate to severe ulcerative colitis, especially for the remission of disease. And once you use or when corticosteroid is indicated in ulcerative colitis, that shows that it is a severe disease. And those who are taking ulcerative colitis or patients who have had ulcerative colitis, patients with ulcerative colitis who had corticosteroids, they are at a high risk of relapse and possibly colectomy, just because the severity of disease, not because of corticosteroid, but because severity of the disease. So after the initial exposure of corticosteroid, 2/3 will require a reintroduction of corticosteroids at some point of time in the course of disease, and 1/3 will become steroid dependent over time. So when you look at the course of treatment for ulcerative colitis, those patients, the patient only after they require first corticosteroid exposure, and they then continue with 5-ASA and they are fine and do very well. Some patients, they require more than one cycle, or even after one course of corticosteroids, they require more and more frequently for that. And those group of patients, some patients when you start steroids, they don't respond very well. And those patients, we try to classify them as steroid failure or steroid dependent and steroid refractory. So we have 3 situations of corticosteroid failure in ulcerative colitis. One is steroid dependent, where you are not able to wean from steroids, and this steroid refractory, in spite of giving adequate dose, they are not responding. And the response of steroids in ulcerative colitis, acute severe ulcerative colitis, is a different entity that we have already discussed. I'm not going to it. So there are 2 major areas. One is steroid dependency and steroid refractory. And I'll be concentrating on steroid dependent ulcerative colitis. Steroid dependency means it defines a disease course that initially responds to oral corticosteroids but fails to taper below the equivalent of prednisolone 10 mg per day within 3 months, or that relapses within 3 months after steroid discontinuation. But in steroid refractory, you have adequate dose of steroids, and the response is inadequate in 4 weeks. And when you give IV corticosteroids in 1 week time, if there is no response, and make sure that there is no infectious complications like CMV, C. difficile, etc. If they are excluded, in that situation, we call them as steroid refractory. So in this situation, when there is a steroid dependency, you need a therapy escalation. I will again stress upon that. Before that, always make sure that you need to have certain precautions prior to therapy escalation, that do diagnostic workups, stool test for infectious colitis, especially parasites, though I don't see it, I don't see it in ulcerative colitis in my area, but there are some studies saying that in northern and some part of India, amoebic colitis becomes an important infection. But more frequently we see Clostridium difficile, and it's, I am sure all over India we are seeing more and more C. difficile infection. Another thing is you need to do a sigmoidoscopy, very restricted, that is to look for cytomegalovirus virus for histopathology, including immunohistochemistry, and also for a tissue PCR, and then also it will give an idea about the disease activity. Are we really having a disease relapse or not? And also another important area is that you have to see that whether the adherence to medication was good or not. Because even at the best of many countries, they have found that 40% of people with 5-ASA, they have got their defaulters. They don't actually, they are poor adherers of medicine. So this is very important to look at that. And also in certain clinical situations where the clinical, if the clinical situation demands, you should do an imaging to rule out associated malignancy or some other complications or that. So when you come to steroid dependency, we know that after checking for the checklist I told you, then there are options are a small group of patients can be tried with azathioprine or 6-MP. And we have to see that those patients who are less likely to go for disease progression, or low risk for disease progression. How do you know about low disease progression is that if they have responded to their first dose of steroids, there in those patients, sometimes they may do very well with azathioprine. There are no studies on that, but in at least one group, we should try in patients. We should try to do a challenge of or a trial of azathioprine or 6-MP. But in almost all other situations, the patient requires a biologic, and the biologic choices are different and depends upon the cost, many other aspects, availability. Everything becomes important, and in those patients, we need to start biological therapy, either for induction as well as for maintenance therapy. And most of the time, these patients actually requires a maintenance therapy because, and most of these drugs, biologics, are found to be useful. So once you start the biological, that the how you manage a biological therapy in ulcerative colitis or IBD, you have to do like that. If the patient has got failure, then you switch out after or in between, or if the patient has no response, you actually do a therapeutic drug monitoring, and depending upon that, you plan your treatment. Or when there is again failure, then you consider about switch out of class or take up the patient for surgery. So in our situation, we have a low risk of progression. In those patients, steroid-dependent colitis, you can try azathioprine or S6ME trial. Or those patients with a high risk of progression, you need to have biologics. But in most of the situations, one may require biologics. So coming to biologics, we have got different types of drug available now. And mostly is our anti-TNFs, which includes infliximab, adalimumab, and golimumab. Then we have vedolizumab and latest introduction of ustekinumab, which is not available in India. But small molecule tofacitinib is readily available in India, and it is going to be more commonly used in India. So when you look at the pharmacological characteristics of tofacitinib and when compared to the biological agents, the most advantageous is that it's orally administered and it's a very rapid onset of action. So when you look at the endpoint evidence of biologic trials in all these different, infliximab induction is good, maintenance is good, mucosal lesion is quite good, and it's also useful in acute severe ulcerative colitis. When you take adalimumab, yes, induction okay, maintenance okay, mucosal okay, but not recommended for acute severe ulcerative colitis. Golimumab, same. Vedolizumab also same. It's not recommended for acute severe colitis. Ustekinumab, the data is not good for acute severe ulcerative colitis. But for tofacitinib, yes, this is all features are there, and probably this is a drug which can also be considered for acute ulcerative colitis because of the rapid onset of action. But the data is still lacking. We need more data on that. When you look at median hospitalization, clinical guideline is said in those patients where you need to start biologics. Generally, any biologic, infliximab, adalimumab, golimumab, vedolizumab, tofacitinib, ustekinumab, all have equal or reasonable response in patients who wants to be started on as maintenance therapy, especially on steroid-dependent patients. So coming to tofacitinib, it is actually a new drug. I thought I will just say something about clinical remission. It is found that corticosteroid-free clinical remission is reasonably good in patients at week 8, and which again it is reasonably good. And a sustained corticosteroid-free remission was found in 33.6% and 31% at the end of 6 and 12 months. Mucosal healing is ranging from 41 to 13 patients in variable week 8 and 16. So it has got a reasonable sustained response, and also it has shown that probably colectomy rates also come down. So there is a big question comes: are we doing justice by starting biologics? Does biologic therapy impact colectomy rates in ulcerative colitis? The data says yes. There is a time trend analysis done in USA on ulcerative colitis ranging from a period of 2007 to 2016, and they found that the usage of biologics, different types, including combination, is on the rise. And similarly, they also found that the colectomy rates is gradually coming down because of probably biologics too. But the quality of life, the treatment modalities, all has favored in that, and biologics partly made an impact on the treatment or reduction of colectomy rate. It's also shown that as the biologics usage increases, the colectomy rates also comes down. So there is some scientific evidence for that. So suppose you want to position your treatment of biologics in acute severe ulcerative colitis, infliximab stands first, then probably tofacitinib, though we have no data very strong on that, but this is a current opinion given recently shown slide. But probably in India, this may be very useful because tofacitinib, and this is the Western recommendation of outpatient moderate to severe ulcerative colitis, which actually comes the classical steroid-dependent ulcerative colitis. They have suggested vedolizumab and ustekinumab. Vedolizumab basically because of gut selective, and infections are less. and then infliximab, and then tofacitinib, and finally golimumab. And we know that adalimumab is not a wonderful drug for ulcerative colitis, especially in acute severe ulcerative colitis situation. But I think in India, this position chart will change. Tofacitinib may come higher up, or the number one, number two in patients with ulcerative colitis for maintaining management of moderate to severe ulcerative colitis. But we need more data on that, and I'm sure this is going to work because of many reasons. One is the oral intake, and also has got availability, cost, and many factors are there. So I would like to conclude my talk by saying that nearly 1/3 of ulcerative colitis patients become steroid dependent. Escalation therapy becomes essential in this particular group. Check for infections and drug adherence before escalation therapy. A small group could benefit by azathioprine. Biologics are the mainstay of medical therapy in steroid-dependent ulcerative colitis, and biologics could reduce the lifetime risk of colectomy. Infliximab and is the most commonly used anti-TNF, and anti-TNF is at present the most commonly used agent as biologics. Small molecules like tofacitinib has an advantage of oral administration, therapeutic effect, cost advantage, and reasonable safety profile. So this is going to become probably an important drug, at least in countries like India. Thank you so much for your patient hearing.
Thank you, Mathew. You will wait till GV finishes his talk, because then you will have to take the questions. Shobna
Sure.
and Sumit will talk to you.
Thank you so much.
Yeah. GV Rao, for some of you who are not known, is in charge of the surgical unit at Asian Institute of Gastroenterologists. He's a very accomplished endoscopist, not only a surgeon, but an excellent endoscopist, wonderful debater. And today he is going to tell us on the surgeon's perspective on the same subject.
Thank you, Rupa. At the outset, let me apologize for this most unscientific presentation of low impact, basically because I was supposed to talk on steroid refractory ulcerative colitis tag in India. So I'm supposed to quote all references from India and not to quote any high impact journals. So it is like comparing the Nature Journal with Indian Journal of Surgery. So if you look at any piece of art, the perception of individuals who are looking at a piece of art seem to be different. Ulcerative colitis the management seems to be an art, and we have an industry perspective to it, a clinician's perspective to it, a surgeon's perspective to it, and a patient's perspective to it. And of course, you're adding a tagline of India, so you have a nation perspective to this. If you look at the ulcerative colitis, there is no doubt that India, we had this low incidence area with an increase in incidence of this. But if you see the latest graph, it shows that India is almost touching the Western world. Phenotypically, this disease seems to be similar to what is happening in the West. And gut microbiome wise, there seems to be variation in mild to acute severe colitis. And there also seems to be some difference between East and the West. This I'm taking references from all the publications that have come. Genomic wise, they feel that the IBD that we see in India is totally different from the IBD that we see in the West. I hope I'm correct in this. Correct me if I'm wrong. So basically, we are talking about a made in India ulcerative colitis, and we're not comparing with the Western data as in today. As in today, whatever we are talking about, it's a made in India ulcerative colitis. Now, if you take it from the industry perspective, now India is supposed to be the emerging hub for biologicals and biosimilars. And India's biological market is supposed to be hitting at 12 billion by 2025 and is sharing a huge market of the global market. And I'm sure it is going to be one of the biggest players in the market of biologicals. And from the industry point of view, surgery is not a presentation worth giving any screen or a podium presence in this sort of a meeting. I apologize for the industry partners here. So ulcerative colitis and biologicals, actually the biologicals they are made in India and they're made for India. We need biologicals. make for India biological. We need make for India biologicals, not that somebody is making biological and they're sending it to India. And there are several issues that we are concerned about: the cost, the compliance, the complications, the choice of the patient, and the incidence of cancer in this patient with ulcerative colitis. Maybe you can call this the C factor in acute severe colitis. There is no doubt about the indications of surgery in toxic megacolon, massive hemorrhage, and perforation, but the gray area seems to be the steroid refractory ulcerative colitis. Surgery has evolved from the very basics from open surgery to laparoscopic surgery over the periods of time. And as in today, I'm not talking about any open surgery in current day clinical practice, because most of the people have switched from open to laparoscopic surgery because of the recent advances in laparoscopic surgery. I'm not trying to show that just trying to show that laparoscopic surgery, what is talked about, a laparoscopic subtotal colectomy that you do in an acute severe colitis, is a feasible thing. And it is the procedure of choice that is done in most of the center. I've seen some of the data that has come from our Indian counterparts from Delhi. So the best part of it is actually after we do a small incision actually and take out this entire piece of colon laparoscopic subtotal colectomy, we are avoiding any major incision so that the post-operative complications in these patients are very, very minimal. So it looks something like this. End of the thing, you take the specimen out, do a small incision that you make in the supraumbilical region. And once you've done this, actually as a second stage procedure, you do this pouch reconstruction. When this patient comes back, actually you do this pouch reconstruction. And for want of time, I'll just show you that this is how it is stapled to the lower this thing. And as of today, we leave a small segment of the thing above the anorectal junction and do a staple anastomosis, which is the standard of practice as of today. So there are a lot of potential benefits of this. Though the operative time is slightly more, the post-op morbidity, length of hospital stay is less, and there are comparable functional results. The wound infections are less, and the intra-abdominal infections are also less, and the hospital stay is very less. And they have comparable incidence of ILS and GI bleeding as compared to the open surgical procedures. We have some Asian data which show that it is as safe as open surgery, and the specific complications like peritoneal abscesses, leaks, and intestinal obstruction are similar in both laparoscopy and open. And if you compare this with what we do for our familial polyposis of coli, it is shown that the results are equally good. There is no difference between the pouch procedure that we do for a familial polyposis and for an ulcerative colitis, except that we do a 3-stage procedure in ulcerative colitis compared to a 2-stage procedure in polyposis. In the era of biologicals, if you see, beautiful paper that came from the All India Institute, which showed that if you delay this patient, if you delay beyond the 3-day mark that Ajay was talking about, and if you see the mortality is very, very high, and all these patients who died are patients whom the surgery was delayed beyond the 3rd day. And we have the same institute which has published this, which shows that, which reinforces the clinical policy to offer early surgery in these patients with acute severe colitis, less than 7 days, 3 days of the cutoff point. And we have also shown from Indian data that the type of surgery does not differ just because the patient has got a left-sided colitis or a pancolitis. If the patient has to come for surgery, the standard of surgery is a total proctocolectomy with a pouch reconstruction. We have this Indian Society of Gastroenterology consensus. These are not the surgical gastroenterology consensus, but the Indian Society of Gastroenterology consensus, which shows that the grade of recommendation for surgery is very, very high in this patient. And you have to consider surgery as the procedure in all these patients with steroid refractory ulcerative colitis. What do we do with these patients who have come after biologicals actually? Now, there is beautiful data that has come from Ajit Sood's group, which says that 56% avoided colectomy at 2 years. From the surgical perspective, I'll put it the other way around. I'll say 44% required colectomy in this patient. So basically, and we have the long-term surgical results of QC in biologicals. You can see that the colectomy rates at 5 years seem to be very high. At 2 years, it looks very interesting. But when you follow up these patients on long-term follow-up, majority of these patients seem to be ending up with colectomy. Do biologicals change the type of operation in patients with ulcerative colitis? Absolutely no. Umpteen number of references, both international and national, show there is no difference in the type of surgery. Are perioperative complications increased in patients with UC and biologicals? Now, this is a variable debate. There are pros and cons. Some evidence shows for, some evidence shows against it. But as in today, we know that actually whenever these patients are on biologicals, it is likely that the post-operative septic complications are slightly more than the patients who are not on this, because patients are already on steroids. Adding your biologicals, it is likely that the infective complications are slightly more. And we have this beautiful meta-analysis, which is also variable, which shows that these patients, the complications could be as good or as bad without biologicals. Now, if you see this beautiful data, which came from the Asia Pacific group, actually beautiful paper, which shows high income group countries versus low income group countries. Low income group, they use steroids mostly. High income groups, they use biologicals. But irrespective of the low income group or the high income group, the colectomy rates seem to be similar. Please take this carry home message. The colectomy rate, whether using steroids or using biologicals, the colectomy rates seem to be similar. Now, this is a beautiful systematic review that includes our own Indian data also. That's the reason why I'm quoting this. And this study shows complications, these look very, very high, but these take any early complication, in the sense like even a small stitch abscess is taken as a complication. Erythema is taken as a complication. But if you see this, there is a lot of data to show that we have improved results over the period of time compared to the earlier results. If you compare the earlier surgery, the open surgery with the laparoscopic surgery as in today, the early infections have come down dramatically, pouch failures have come down dramatically, and the post-op mortality, mind you, it is not 15%, 20%, 40%, it is just 1%. The mortality of these patients undergoing surgery is just 1% and not like 15 to 40% that is quoted. Now, if you see this again, our own from India, we have trends of inflammatory bowel disease in a tertiary referral center. We seem to be getting more and more younger generation people ending up with ulcerative colitis. Younger generation means these people are on medications for a longer period of time. It is likely that these patients should undergo surgery rather than trying to put them on biologicals lifelong. And also, if you see the indications, the failure of medical therapy seems to be increasing in this set of people. And you can see the incidence of colectomies is going up steadily over the period of time in the Indian context. Now we have a beautiful sum up of this from Ajit Suk group, which says, though there is limited clinical data from in 2014, actually, the cost remains a big question. It is prescribed only for those who can afford the cost and have medical insurance, which plays a big role. Pharmacoeconomic studies are needed in future to avail maximum benefits from these drugs, irrespective of the patient's socioeconomic status. And long-term safety data will allow full assessment of risk-benefit ratio for every patient. And we require more investigations to show that these are beneficial. And again, we have some of these extraintestinal manifestations of ulcerative colitis, which can be managed simultaneously if you subject this patient. This is one such report which shows thrombocytopenic purpura associated with ulcerative colitis, which can be treated as a single stage rather than putting these patients on biologicals. Quality of life is very, very important. Since the dietary practices are different from the east to west, the median number of bowel movements per 24 hours is what is taken into account actually. And as of today, the median frequency of stool seems to be about 3 to 5 following this pouch procedure, which is very, very acceptable, and the nocturnal frequency is not very high. Timing of surgery is very, very important. 1/3 of the patient felt that they should have undergone surgery earlier rather than putting these patients on surgery. Please, patients concerned, the patient has to be told in detail about the long-term prognosis, long-term costs, long-term complications of these medications. Unless and until the patient asks the question, we should not take these patients to long-term management with biologicals. Now again, there is increasing incidence of colorectal malignancies in these patients with ulcerative colitis, especially if you follow these patients on long-term, because again, we are seeing these patients at an younger age as compared to what we used to see. Our own data from India shows that there is increasing incidence of cancer in these patients with ulcerative colitis. So it needs screening as a modality, and these patients have to be subjected to surgery at the earliest. So to sum up, from Vineet Ahuja's group, surgery provides a definitive cure, removing the inflamed mucosa, eliminating the future risk of recurrence of malignancy. Semi-elective surgery decreases mortality, improves quality of life, but emergent surgery carries a significant perioperative complications, basically because of the preoperative status. These are the emergency indications. Delaying the surgery with worsening symptoms or development of clinical stability can lead to risk of adverse events. And if we have any of these objective predictors for steroid or biological failure, as in today, I'm sure there are umpteen number of predictors that you follow on the medical side. Actually, I'm sorry, I'm totally unaware of all these things, but they hand over the patient to us whenever they feel that this patient is not responding to any of these objective or subjective criteria that you have. Now, these predictive equations that we have as in today have an acceptable estimation, but they have their own limitations. In spite of following these predictive equations, we seem to be ending up with some sort of complications in these patients. So as in today, algorithm seems to replace these equations. Artificial intelligence seems to be taking place. And I think next year we'll see more and more of these predictors being replaced by this artificial intelligence, which is going to come. There are some publications which are already coming to show how to predict steroid failures, how to predict in biological failure, and at what stage the patient has to be taken for surgery. But these, again, I think there are a lot of limitations to these artificial intelligence. I'll just show you, this is the big data that is coming up to show that AI-based object evidence may predict the response and also the failure to these patients in future. But again, limitations are this. Actually, if you see this beautiful football match, actually using artificial intelligence to scan the football. Unfortunately, the referee is a bald-headed person, and this artificial intelligence does not recognize the bald head and the ball. So the camera is following the referee, not the football. So there are a lot of limitations of this artificial intelligence. Unless and until we have adequate data that is fed into the computer, this will not give the limit. These are all absolute limitations. The camera is absolutely following the referee and it's not following the ball. These are the limitations of artificial intelligence. And again, I'll show you, this is the recent thing that has started about artificial intelligence. We have all heard about this Australian Open final match between, at the end of third match, actually they said the artificial intelligence predicted that Daniel is going to win this match, but at the end of the thing, you've seen what happened. It is basically the sheer grit of the person that is what is responsible for the entire change and rewriting the history, saying that artificial intelligence does play a role, but we have something to do with human values also. So to summarize, biologicals seem to delay colectomy in many patients. The overall colectomy rates have decreased in recent decades. It is not clear that biological treatment has substantially changed the long-term colectomy risk. Treated with biologicals, it means that these patients have more severe phenotype and ultimately may require colectomy. We require further studies are necessary to predict which patient will progress to colectomy with better accuracy than what we have as in today. Surgery continues to play an important role and its evolution keeps in pace with the advances in medical therapy. Restorative proctocolectomy with IPAA, stage procedures and MIS are important tools. MIS limits postoperative morbidity, achieves excellent long-term outcomes. In an attempt to avoid surgery, aggressive medical therapy is not without complications because there are associated complications. Relative young age of presentation, increasing colectomy rate in long term, and increasing incidence of carcinoma should prompt for surgery, early surgery in these patients. A multidisciplinary approach is very, very important. Families, patient may elect to proceed for an elective colectomy rather than to continue on biologicals. And this is very, very important. I think we should have sympathy, empathy, natural intelligence, artificial intelligence, everything put together, not to just go by the evidence, because costs, compliance, complications, and cancer issue can be predictors of medico-legal implications in India. Please, this is not evidence-based, but we know that this is what happens in real time. We have to keep in mind that these patients can be predictors of some medico-legal complications. So for steroid refractory ulcerative colitis, it's a made in India disease. Biologicals are made for India and made in India, but what we need is make for India biologicals. Surgery is truly made for India. Thank you so much once again for the patient.
Wonderful as usual, GV. Well done. Shobhana and Sumit will only take up because one of them is virtual, so you'll have to ask the questions.
So can we have Mathew on the screen? Mathew, would you like to put a rebuttal?
Not a debate, he said.
That's okay, but he can respond to GV. Yes, Mathew, you are muted, I think.
Yes, the host allowed me to unmute, and GV, it was a wonderful talk, and it's an overview of what's happening in the world regarding IBD. I agree that once the current scenario, surgery stands a very it plays a very important role in management of IBD, especially ulcerative colitis, especially the pancolitis, and poor response with the poor response with steroids or to other medications. But we know that if you look at the history, when the medical therapy excels, then surgery comes down. Example, peptic ulcer. When I was an MBBS student, peptic ulcer, always surgery. There were 8, in theater days, 8 cases were be GJ for peptic ulcer. Now I am sure GV will not touch a peptic ulcer unless there is a complication of that. Because you had an effective therapy for that. And when you look at pulmonary tuberculosis, in the past I have seen many patients operated on pulmonary tuberculosis. When effective therapy came in, that went away. And similarly, many other diseases, leprosy, everything. And I'm sure one day will come when you get very effective therapy. If that day is coming, I think it's getting evolved. And with the understanding of the disease is better, and the new therapies come into the field, I'm sure nobody wants, even you don't want a colectomy in a patient with ulcerative colitis, especially in a young patient, but because it's a major important organ. But when it's diseased, you have to do that. But in today's practice, I agree that colectomy has got a very important role. And I'm sure, GV, you compare with the past 20 years, I can tell you 20 years back, my department was doing more of colectomies in ulcerative colitis. But in you take last 5 years, yearly 1 or 2, not more than that. That too with mostly with the malignancies. Not very rarely only we take a patients for colitis, ulcerative colitis surgery. I'm sure Ravu also might have experienced the same thing. IBD surgeons all over the world, they are facing the same thing. They say that many years back they were doing a lot, and nowadays it is less. Thank you, Ravu. It was a wonderful. I agree that artificial intelligence is going to be a very big way. I use endocytoscopy for characterization of ulcerative colitis. I can pick up cells and say that this is actually a severe disease, it's a mild disease. So I think this is going to come in the field, artificial intelligence, and humans are superseded by computers. So that is true. There is no doubt regarding that. I appreciate and thank you for a wonderful talk.
Thank you, Mathew. Actually, I fully will agree with you. Actually, the way diseases are being treated, actually, it is likely that we'll have good medical therapy for this in future. It is not likely that we avoid some of these procedures with morbidity in future. Yes, actually, in future, we are looking forward for these magic drugs which are completely going to resolve. But as in today, in 2022, I think still surgery has some important role in the management of this patient, especially in India. Actually, suppose as in today, we still see, we are surprised actually, we did a recent survey. Everybody used to think that actually that ulcerative colitis or IBD is restricted to the urban areas. But surprisingly, we recently had a survey in some of the rural areas, which we see there's increasing incidence of this IBD in the rural areas. So if you take that into account, I think, as in today, I think we still should keep surgery as an option for these patients. Thank you so much once again.
Thank you.
Can I ask a question?
Yeah, please.
I completely agree with you that in selected patients wherein quality of life is a major factor, surgery does help in steroid refractory and steroid dependent patients. I have 2 scenarios. One, if a patient in the age group of 40 to 50s want to opt for an end ileostomy rather than an IPA procedure, considering that pouchitis rates are not the same across centers, what you showed us slide, that 2% is like very low, and it might be an ideal thing. In practice, it is around 15 to 20% rates of pouchitis, what we practically see. So we have patients who have had pouches made on a diversion stoma, asking for whether they can continue their life like this, and they don't want to ever go back on any medications. And the second one, is there in selected? Okay, sure.
This is a very good question, actually, even today. Actually, though the standard of practice is to do a procedure, actually almost about 8 to 10% of the patient who come in for surgery as in today opt for an end ileostomy. Because there is a familial tendency in this patient. Actually, this especially happens in familial people who have, there are people in the families which have this, in the other person has got severe morbidity because of this, they opt for this end ileostomy. Yes, we are not ruling out total proctocolectomy with the end ileostomy as a surgical procedure in today.
And secondly, in selected patients, especially young females, is there a role of doing the subtotal colectomy and ileorectal anastomosis, and then possibly considering a revision surgery once the family is complete in selected cases? Not
No, I don't think, because see, I mean, especially in acute severe colitis, actually we are not planning for any primary anastomosis. No primary anastomosis. Actually, we have had a couple of patients because we are not doing any pelvic dissection in these patients. Subtotal colectomy is leaving the pelvis alone, part of the sigmoid colon alone. So we are not doing any pelvic dissection. So we are not compromising with any.
I'm asking about a steroid dependent
yes,
category.
even these patients actually, I mean, we do a stage procedure. We are not doing any primary anastomosis in this patient. No.
Any questions from the house?
I think for want of time, we'll close down, Shobna.
Okay, so GV and Mathew, I think this was wonderful. This was a wonderful end to this whole day's discussion, and bringing in a surgical perspective actually made us more awake. Since morning we were discussing a lot of things on medicine, a lot of complicated biologicals, and but I think even though, as GV himself said, that his talk was more practical, there was hardly any theory in it. I think there was a lot we learned from you, and same for Mathew.
Thank you so much. Actually, as
you.
surgeons, actually our IQ is very, very low. And I keep telling people that all these are tongue twisters for us. Actually, I don't know how many people can really spell out all these biologicals actually. Finally, they're all nicknames.
GV, you don't tell that about IQ. You are a computer wizard, and I think you yourself is a human with a lot of intelligence and super added artificial intelligence also.
Thank you so much.